Hello, 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 doctors. How is everyone doing? How is everyone doing? I'm excited to come your way. This is your friend, your brother, your coach as to try to ace the MCQ1 exam. I'm so excited because today we delving into, another very important MCQ1 objective. So we're going to dive right into it more. And as usual, this is your brother, this is your friend. And so let me know in the comment section if you can hear me clearly. And if you can hear me clearly, can you see me? I'm sure around this time you cannot see my screen because I'm not sharing my screen, but I just want to make sure that you can see my background and everything, and then we can jump into it. Today we're going to deal with a very important topic. Um, many times people just talk about red Quran jelly stew, and I think that is all that intersection is about. But there's more to it, how to navigate an MCQ1 objective case so as intersection is concerned. So you can see obviously that I'm going to share my screen, and you realize that this kid is obviously distressed, right? Obviously distressed, yeah, and the child is going through a lot and needs help. And so you as an MCQ1 candidate will need to help this kid. And that is all that the MCQ1 is about. How to keep patients safe, how to keep patients alive, how to protect patients so that they don't deteriorate. And so today we're going to deal with one very important pediatric emergency, solve many questions, and at the end of the class, like what we've been doing, we're also going to do active recall. Because for me, I'm getting to appreciate as we teach everyone that it's not enough to just keep facts, keep facts, keep facts. At times you need to let people dig deep and bring out concepts that they've learned in class. So let's dive in right away. If you have any friends who have not joined us yet, please tell them to join. And if you're on our Facebook, or no, on our YouTube, and you've not subscribed yet, look, we have so many videos for you on the YouTube. Just subscribe, okay? Because if you subscribe, it helps us to also get the whole thing to other people. Okay, so just subscribe. Currently, let me see where are we? Where are we with our subscriber count? And every day we're getting new subscribers. So today we are at. I'm just checking it for you. I'm just checking it for you so you can all help. So if you are on this live and you've not subscribed yet, please help us to. Currently, we are at 2,386. Let's move it to 2,500 today. 2,500. So we need about just a little over 120, 130 subscribers. So if you're on the live today on YouTube and subscribe, go in there and subscribe. And let's, okay? So someone is saying the voice is not clear. Is it better now? Hello, doctors. Is it better? Is the voice better now? Let me see. Uh, we do this with you, so I'm very happy about the feedback you give. Okay. Let me see. Please, can you hear me now? Is it better? Better? Let me know. Is the voice better now? I've changed the microphone. Is it better? Is it better? If it's better, let me know that it's better. Or is it still breaking? It's better. Okay, Dr. Ronnie Lankela says it's better. Okay, good. Dr. Mueller John also has confirmed it. So good. So we're jumping right in. And then we're going to study. So intussusception. So now the question is that where does intussusception fall under the MCQ1 objectives? Okay, where does intussusception fall under the MCQ1 objectives? And you realize that there's this objective called pediatric diarrhea. Pediatric diarrhea. So let me unshare my screen and then take you to the MCQ1 objective itself. Pediatric diarrhea. Pediatric diarrhea, and then see if you can appreciate why I'm dealing with this particular topic today. So the screen, pediatric diarrhea, awesome. So if you look here, doctors, please, are you watching? Pediatric diarrhea. This is the MCQ1 objective, and if you go into our objective book. If you don't have it, the summarized MedCognito objective book, you'll also find it there. The reason why I'm dealing with it is there are various causes of objective of diarrhea, and then there is the ischemic intestinal damage cause, which is intussusception. Okay, so that is the reason why we're dealing with this, because it will come out in the class that there are various critical things that we need to also master. So that is why we are dealing with intussusception today. So every topic we decide to deal with are critical. It's critical for your exam preparation. So let's get into the presentation itself, and then uh, take it from there. So where do I go? Okay, sorry. Let me. Okay, let me share my screen. The class will begin. Okay, good. I think I see my screen now. Okay, so where does it fall? It falls under pediatric diarrhea. Okay, now the causal conditions, as I said, in pediatric diarrhea for MCQ1, they want you to master infectious causes of diarrhea, diet-related causes of diarrhea like tolerance. Okay, then they have something they call ischemic intestinal damage. That is intussusception. Okay, so ischemic intestinal damage, and then there are infections, malabsorption cases like lactose deficiency, cystic fibrosis, celiac disease, and then other causes of diarrhea like drugs, laxative abuse, and inflammatory bowel disease. So, doctors, please, I say this and I'll say it every day. I'll say it all the time. If you want the MCQ1 objective, summarize. If you want to keep it in two-page document, send me a WhatsApp right now on 306-891-5649. I'll get you a PDF copy. This is very, very important. So don't study amiss. Okay? Don't study amiss. Make sure that everything you're studying is in the MCQ1 objective. So we're going to just get into some questions because today we are focusing on intussusception. And of course, the first question will give itself away. And it says that you have a 9-month-old previously healthy male who is brought to the emergency department with intermittent episodes of crying, during which he draws his knees to his chest. Um, his mother reports that he vomited once and has had decreased appetite over the past day. On examination, he's irritable but consolable, and his abdomen is soft with no palpable mass. His last bowel movement was yesterday and appeared normal. Which of the following is the most likely diagnosis? A. Pyloric stenosis. B. Hirschsprung's disease. C. Intussusception. D. Gastroenteritis. And E. Malrotation with volvulus. What's the correct answer? What's the correct answer? What's the correct answer? So the correct answer is C. We are discussing intussusception anyway. And what gives the various parts away? So let's learn how we're going to separate intussusception from the other conditions like Hirschsprung's and the rest. So intussusception is the most likely diagnosis because of the classic age, okay? 9 months. And the fact that the kid has episodic crying with knee chest position. And when you see a child like that, that suggests colicky pain. And vomiting and decreased appetite are early non-specific signs of intussusception. By the way, pyloric stenosis, how will pyloric stenosis present in a board exam situation? Usually, um, the baby is presented as maybe between 3 to 6 weeks of age, and the vomiting is presented as projectile non-bilous vomiting. Okay, projectile non-bilous vomiting and a palpable olive-shaped mass. That is how pyloric stenosis is presented in the board exam. What about Hirschsprung's disease? Hirschsprung's disease is also presented as a child who has delayed meconium passage. They may have abdominal distension and chronic constipation. So please, if you can be able to pick up these things very well, that makes things easier for you. What about more rotation with volvulus? If you want to pick up that in a board exam situation, usually you realize that that child presents acutely It's an acute presentation, and there's bilous vomiting, and usually there's signs of peritonitis or sepsis. Okay, so that's something you want to really pay attention to. How to separate intussusception from pyloric stenosis, from Hirschsprung's disease, from gastroenteritis, from more rotation with volvulus. These are very critical things you want to pay attention to. Now, this is a very, very important question, and I'll be highlighting on it even in the deep learning phase and then the active recall as well. Now, which of the following locations accounts for the majority of intussusception cases in children? All remember that common things are common. A, is it the jejunal? B, is it colic? C, is it ilio-ileal? D, is it ilio-ileocolic? Or E, is it ileocolic? Where do you see most intussusception cases? About 90% of them. Where do you see about 90% of them presenting? Please let me know. Is it A, jejunogenital? B, colocolic? C, ilioileal? D, ilio-ileocolic? Or E, ileocolic? Okay. So I see a lot of candidates going for E as ileocolic, and that is the truth. So please write in your book. Majority of intussusception occurs in the ileocolic region. Okay, ileum, that junction between the ileum and the colon. That is where about 90% of cases of intussusception occur. The rest are less common, and they are often associated with lead points. And I'm going to explain the concept of lead points as we move on. Ileocolic is the commonest. So please write it in your book, and as usual, take pictures, send it to me on my WhatsApp, try to warm my heart a little bit. Okay, +1 306 891 5649 +1 306 891 5649. And while we do that, please don't forget to subscribe to the YouTube channel as well, so that we can help you grow and get the message of MedCognito to the entire world. I really want doctors everywhere: Pakistan, India, Iran, Ghana, Nigeria, South Africa, you know, Southeast Asia, North America, Canada, everywhere, to see what we are doing for the IMT community. So the answer is E, E, E. Now, which of the following statements best explains the age-related incidence of intussusception? Which of the following statements best explains the age-related incidence of intussusception? A, it is most common in neonates due to immature bowel motility. B, it peaks between 4 to 36 months due to lymphoid tissue hypertrophy. C, it increases steadily from infancy to adolescence. D, it only occurs in children who are immunocompromised. E, it is uniformly distributed across all pediatric age groups. What's the correct answer? Is it B? Is it C? Is it D? Or is it E? Let's go. Let's go. Let's go, guys. Let's go. Let's go. I've only seen a few answers. Please, we have more than 100 people on the live. Please kindly click on the correct answer. Let me know what the correct answer is. I think some people are struggling to join the live. I'm going to do my best to send them the link right away. Okay. I've sent them the link. So I don't know. Some people are saying the audio is not clear. Doctors, is there a problem with the audio at all? I thought we fixed the audio. Is there a problem? Can you hear clearly? Can you clearly? I want to know before there's so much to do today. I want to know, is it clear? Is the voice clear now? Oh, okay. So they are saying there's some choppiness in the voice. Let me see. Let me try something different. Uh, just give me a few seconds. Okay. I've changed phone. Is it better? Please, doctors, is it better? I want to know which one. Voice better now, or is it still breaking? Is the voice better, or is still not break? It's still breaking. Worse. Okay. Let me see. Just give me a few seconds. Let's. Uh, better. Hello. 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 Better. Is the voice better now? Is the voice better? Yes or no? I just changed the microphone again. I've changed almost 3 microphones. Now, is it better? Oh no. Ooh. Okay. So what do we do? So someone says it's better now. Hmm. Okay. It's better. All right. Okay. Okay. Then I'm not going to touch anything. Okay. Let's just go. So if it's better, then let's go. Okay. Awesome. Okay. So which of the following treatments best explains age-related incidence of intussusception? Okay. A, it is most common in neonates due to immature bowel motility. B, it peaks between 4 to 36 months due to lymphoid tissue hypertrophy. C, it increases steadily from infancy to adolescence. D, immunocompromised. And E, it is uniformly distributed across all pediatric ages. And the answer is B. B. Please go for B. The truth is that the peak incidence of intussusception is between 4 to 36 months. Okay. And it is often triggered by lymphoid hyperplasia. We call that Peyer's patches, okay? Especially after viral infections. And today, we're also going to learn the most common viral infection, which at times can precede, um, um, which can precede these situations. Neonatal intussusception in a neonate, a newborn baby, is rare. If you see that, you've got to think about what you call a lead point, a different lead point. And most children are healthy and well nourished in who have intussusception. Okay, now a 6-year-old boy presents with abdominal pain. We suspect intussusception, although this age is beyond the peak incidence. What is the most appropriate next step in this case? So we don't know what is intussusception, and we know that the commonest area intussusception occurs is ileocolic. So what are we going to do? Assume it's idiopathic and observe the child. Two, order an abdominal ultrasound and prepare for contrast area reduction. C, begin empiric antibiotics for appendicitis. Because ileocolic, appendix also around that place. D, refer directly to surgery for appendicitis. Sorry. And E, order abdominal CT without further work. And this class is also going to teach us the indications for requesting abdominal CT scan as well. Okay, so let's look at all these things. What are you going to do? Assume it's idiopathic, and the question is, in who is 6 years of age, who has suspected intussusception, is it idiopathic or is there a cause? Mm-hmm. So that is what you are being tested on. And the correct answer is B. So in children over 5 years, now look at this. Intussusception can still occur, but it's more likely due to a pathologic lead point. For example, Meckel's diverticulum. And ultrasound is the first line diagnostic test. Please, I need you to write this down and take a picture and send it to me. Ultrasound is the first line diagnostic test. So Dr. Julie, oh my goodness, she's just scribbling away her life into intussusception. That's beautiful, Dr. Julie. Thank you very much. I like your brown table, and thank you for sending me that awesome picture. And so, doctors, ultrasound is a first line diagnostic test, okay? And non-surgical reduction with enema is still appropriate if there are no signs of perforation or peritonitis. So ultrasound is the first one. Always remember that. Ultrasound is the first line. Okay, good. Now, so let's look at this. Let's look at this very well. Um, Intussusception. When you're thinking about intussusception, think about a telescope or a socks folding into itself. Okay. So what I've done is I brought my socks. I brought my socks. Let me unshare the screen. I brought my socks. Okay, so think about it. Intussusception. Think about this. This socks is clean. It's clean. It's a clean socks. Okay. Now, then think about this as the interest. So what is intussusception, by the way? Intussusception is basically this part going into this part. So, this part going into this part. This is basically what intussusception is. So remember, it is like this, and then this part, as like the body, the intestines are moving by peristalsis and moving the food along. Then something happens, and because of that, one part of the intestine gets into another part, right? So it becomes like a telescope. Like the way telescopes, you can pull it in and pull it out. That's what we call the telescoping. Okay, that's what we call the telescoping. So doctors, please, I hope this makes a lot of sense. So think about the intestine like that. Okay, Dr. Bruni's socks, and then one part moves into another like that. And so because of that, there's a problem here, right? And you basically want the thing to come up like that again. So this is intussusception. So think about scopes or socks folding into themselves. Okay. And when a section of the intestine slides into a nearby segment, then we call that intussusception. Okay. Now, I brought you um I brought you a picture so that's confirms what I was talking about. Um you guys are just joking. So I says his socks needs to read 4 months, 36 months. Uh, okay, so there's telescoping. Okay, so one part of the bowel moves into another part. The part of the bowel which moves in is called the intussusceptum, and the part of the bowel which receives is what we call intussuscipiens. Okay, so I'll go back to put my picture on again. So the part of the bowel which moves in is called the intussusceptum, and the part of the bowel which receives is the intussuscipiens. So if you can see here, okay, this part of the bowel has moved in, and when you think about it, why is it serious? Because it affects blood flow. It affects blood flow, and then that can become a serious issue. So 75% of it is geographic. Most of the time, no obvious cause between 3 months to 5 years. And that's why I said that if you have a kid who is having symptoms of intussusception and it's occurring before 3 months, there's a problem. It could be that there's a lead point. If you also have a kid who is about 5 years, who is having symptoms of intussusception, it means there's a problem. Most of the time, can intussusception be triggered by viruses? Yes, it can be triggered by viruses. And so you realize that the peak incidence of intussusception is when the viral season, like during winter, when there's gastrointestinal infection outbreaks in communities. Most of the time, in about 30% of cases, you can also get an upper respiratory tract infection preceding the presentation. So that's also something you want to pay attention to in a board exam. Child comes in, 9-month-old child. Mother says, "Oh, the kid had runny nose, runny nose," and then later on the kid is having abdominal pain. The abdominal pain comes and goes. When there's abdominal pain, the kid will cry, and then the kid may have some relief. Think about it. Now, the former rotavirus vaccine, it is called RRV-TV, was also pulled off the shelf because of the increased risk of intussusception. Okay, and then infections like adenovirus also have a very strong link. So this is it. I was telling that there's one viral one viral preceding cause of intussusception. So one virus which you should know and which you should master and put in your notebook, it's adenovirus C, adenovirus. Even if you remember adenovirus, you're good. What happens is that adenovirus stimulates what we call PS patches. Okay, so I bring back my socks again. So the PS patch is like, um, so this is the kind all these lymphoid tissue from the intestine. So the kid has like a respiratory tract infection, he has some systemic reaction, and then the PS patches react, they become bigger. The intestines are going, the intestines are going on their own, and then because there's it's infected this bump here, then what happens is as it's moving, then that bump can become what we call like a lead point, and then the interception can occur. So that is basically that. Um, 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 PS patches as a result of adenovirus infection. Okay, PS patches as a result of adenovirus infection. So that's what a PS patch looks like. I really want us to understand the concept. So think about this moving on its own, and it has all these weak points, the PS patches. And so the intestine can then, it's like the intestine is running over a speed bump, and then an accident happens, and then one telescopes into another. Okay. Apart from the adenovirus, we have some bacterial enteritis which can also cause intussusception. For example, Salmonella. For example, Shigella. For example, E. coli. For example, Campylobacter. And their mechanism is that they cause inflammation, leading to lymphoid hyperplasia, and they can also serve as functional lead points. Usually, the bacterial cause of intussusception, the bacterial which leads to like the lymphoid hyperplasia, which leads to these functional lead points, they occur within 1 month of the bacterial infection. Okay? They occur within 1 month of the bacterial infection. Now, why is intussusception critical? Because when there's the telescoping, okay, remember there are blood vessels on the wall. So when there's the telescoping, what happens is that there is venous congestion, and that venous congestion can lead to edema. And when that edema occurs, so can you imagine this place has become they become swollen. It can lead to ischemia. And when ischemia means blood flow is cut off. That is why in the MCQ1 objective, it was stating that one of the causes of diarrhea can also be an ischemic cause, and intussusception is the main one they want to focus on. That can lead to necrosis, and that necrosis will lead to perforation, and that perforation can then lead to peritonitis. So just think about it that way. Blood supply is cut off because of the telescope, leads to edema, leads to ischemia, leads to necrosis, leads to perforation, and then it can lead to peritonitis. Now, why is intussusception important to know for your MCQ1 exam? Because it is the number one abdominal emergency in children under 2 years of age. The number one. That's why I always say that common things are common. Therefore, learn the common things. So, okay, diarrhea, abdominal pain. Okay, abdominal pain in a child less than 2 years. You can revise everything. If you don't revise intussusception, man, you've not revised it. The medical council has taken it there. And if you look at the statistic, the number one abdominal emergency in children under 2 years of age, and you don't learn for the Q1, no. So that's why I always tell my candidates, common things are common. And that is why we are learning about intussusception. Now, when is it most common? We've learned it in one of the questions, between 4 to 36 months, 4 months to 36 months. The other beautiful thing is that you have to remember that it is more common in boys or males as compared to females. Slight, edge in the males as compared to the females. So it's a 3:2. So out of every 3 boys who develop intussusception, 2 girls develop it. Okay? So in your MCQs, remember these facts, right? Remember these facts. More common in boys. Adenovirus, salmonella, PS patches, telescoping, right? Now, this is the beautiful thing. If you have a child who is more than 5 years, I want you to learn this trick, who is presented in a board exam situation with symptoms of intussusception, always look for an underlying cause. Let me say it again. In a board exam situation, if you are presented with a child who is more than 5 years, with symptoms of intussusception, and we'll go through that. Please always think about a possible underlying cause, like a Meckel's diverticulum, like a polyp. Think about possible intestinal lymphoma, enlarged lymph nodes, tumors, even intestinal polyps as well. These are the things you want to think about. If you are presented with a less than 3 months or a child more than 5 years, this is a trick I really, really want you to do. And then, as we learned, 90% of it is ileocolic. Okay, these are ileocolic, vaginal, and colocolic. It can happen in all these places, but remember, all the time, common things are common. Common things are common. Ileocolic is where about 90% of it occurs. Now, give you this table. You can take a screenshot, or you can write the details in your book, because it's very, very critical. Because you can be quizzed on the various causes of lead and how they should present. You can be quizzed on them. Okay. So, what is the number one point in children? It is Meckel's diverticulum. Okay. So, in these children who are about 5 years, what is the number one cause of lead point? It's not a large players party specific. Meckel's diverticulum. Please write this down. Meckel's diverticulum. Now, you can also have patients who have endometrial cysts. Okay, that can lead to a structural issue. That is what has led to the intussusception. And lymphomas, which lead to intussusception, where do you usually find them? You usually find them on a small bowel. Lymphomas, which lead to intussusception, usually are found on a small bowel. Polyps, which lead to intussusception, usually you find it in patients with Jager's syndrome. So, doctors, that's what I'm saying. This table is very important. Very important. When you're learning about intussusception, don't just learn about red Quran jellies and then you move. No. Remember, you'll be presented with intussusception in the context of cystic fibrosis. How do you pick that up? Look for that child with thick stool plugs, and these can serve as lead points. Okay? If you have a child with cystic fibrosis, look for a child with thick stool plugs, and they serve as lead points. What about swollen purpura? That is IgA vasculitis. Usually, you have bowel hematomas post purpura. Okay? You even have an inverted appendiceal stump where a child has had surgery, appendectomy, and that stump where the appendix was taken can serve as a lead point as well. And then we even have parasites which can also lead to intussusception. For example, ascariasis. Okay? And then patients with vascular malformations, they can also have those vascular malformations serving as focal points. Doctors, please, does this table make sense? Please, does it make sense? If it makes sense, type yes. If it makes sense, please type yes. I want to know, does the table make sense? Does the table make sense? What's the relationship between cystic fibrosis and intussusception? What's the relationship between Meckel's diverticulum and intussusception? Okay, good. Again, is the sound better? Because someone is saying the sound is not clear. I don't know. Because I thought we have dealt with that. Dr. Norman, is the sound is not clear. I don't know. Is it better now? I hope the sound is better now. Okay. So the sound is not good. Interesting. Okay, let's try something different. Okay, can you hear me? Can you hear me now? Is it better now? Is the sound better now? I've changed the microphone again. It's okay. Okay, someone says it's okay. Doctors, do you all agree that the sound is better now? Okay, sure. So if it's better now, then we can move on. So it's better. Okay, let's go. So always remember that how the intussusception after a recent upper respiratory tract infection, colon purpura or abdominal surgery should prompt you to look hard for a lead pump. Okay, that is something you want to check out. If a child has had recent upper respiratory tract infection, colon purpura, and abdominal surgery, look hard for a lead point. Okay, so let's review some questions then. Let's review some questions. You have a 10-month-old infant who is brought to the emergency department with episodes of inconsolable crying and vomiting. The child had a mild upper respiratory tract infection a week ago. Abdominal ultrasound reveals the target sign in the right lower quadrant. What is the most likely explanation for the development of this condition? What is the most likely explanation for the development of this condition? A. Delayed neural crest cell migration. B. Hypertrophy of PS patches triggered by recent viral illness. C. Chronic inflammation from small bowel lymphoma. D. Conium ileus due to thick stool obstruction. And E. Autoimmune vasculitis with mucosal ulceration. I'll try to change the microphone again while you solve this question. Let's see how things go. So I've switched to a different microphone altogether. Let me know if it works for you, because I don't know what to do again. uh, I've put a different microphone altogether. Is it better now? Is the sound better? Okay, I've switched to this microphone. So if it's better, let's go. Okay. All right, good. Okay. So the correct answer is B, hypertrophy of PS patches triggered by recent viral illness. Okay. And we learned today that adenovirus and other viral infections can stimulate lymphoid hyperplasia like, PS patches, especially in the terminal ileum. And it creates a transient lead point, like what we call idiopathic intussusception. Okay. Next question. A 7-year-old child known hemophilia purpura presents with sudden onset colic abdominal pain. He had recently recovered from his rash and joint symptoms. What's the most likely mechanism of his abdominal symptoms? A. Stricture formation from chronic inflammation. B. Autoimmune vasculitis causing perforated ulcer. C. Submucosal hematoma acting as a lead point for intussusception. D. Reactive vasculitis of the mesentery. And E. Due to systemic vasculitis. Answer A, B, C, D, or E. And the correct answer, as many of you are getting, is C. In henocolon purpura, intestinal wall hematomas may form after resolution of systemic symptoms, and they can lead as lead. They can then serve as lead. Okay. Now, another question: which of the following patients is most likely to have a pathologic lead point? Okay, as the cause of their intussusception. Let me say it again. Which of the following patients is most likely to have a pathologic lead point as a cause of their intussusception? A. A healthy 10-month-old after a recent viral illness. B. A 2-year-old with rotavirus gastroenteritis. C. A 5-week-old newborn with venous vomiting. D. A 3-year-old recovering from bacterial enteritis. And E, a 9-month-old on a gluten-free diet for celiac disease, which of the following patients is most likely to have a pathologic as a cause of their intussusception. Is it A? Is it B? Is it C? Is it D? Or is it E? What's the correct answer? Remember, we said that there's an age range where um um intersection is most common, right? Now, which of these people fall out of that age range? That's the first question to ask yourself. Which of these people fall out of that particular age range? And the correct answer is C. That's 5-week-old baby. That's 5-week-old baby with bilous vomit. Remember that intussusception in children less than 3 months and more than 5 years, you want to look for pathological influence. We've said that in the previous instance. And the only one who falls out of that group is this 5-week-old newborn. Okay? And most of the time, intussusception does not even start right from the word go with any pilous vomiting. So when you see a 5-week newborn with pilous vomiting, there may be a problem, right? So, how will a patient with intussusception present? Now we're moving into presentation. The classic symptom, I always have what you call the three C's, one V, M. Three C's, one V, one M. They will have pain. It's usually sudden because the telescope happens, right? Intermittent, severe, colicky abdomen every 15 to 20 minutes. Because at times the telescoping can occur and move out. It can occur and move out. Okay. Then that child is crying. The child has inconsolable cry. You see that the child is described, the knees are drawn to the chest. Okay. And whenever they are crying, they are pale during episodes. And then they can have currant jelly stools, okay, where there is mix of blood with mucus. And usually when they present with currant jelly, it's a late sign, and they can have vomiting. Most of the time, that's why I was saying that the vomiting situation in that child, most of the time, okay, is non-bilous. Again, my goodness. Hello, doctors. Can you hear me now? Is it better? Is it better? Can you hear me? Is it better? Okay. Uh, okay. All right. So I don't know. Now we are getting some. I think what I'll do is let me just end the stream and then let's restart the stream again. Okay.